Before your presentation starts, I'd like to take a few moments to introduce you to the City of London Dental School. We're a private postgraduate dental school based in London and run from our college facility at Southgate. Here we offer a number of various programs, both short and degree programs. At present, we offer 6 MSc titles validated by the University of Bolton. These include clinical dentistry, orthodontics, periodontology, pulpal therapy and endodontics, restorative and aesthetic dentistry, and the specialist practice of restorative aesthetic dentistry combined with implantology. These are delivered from our state-of-the-art teaching facilities, and to be introduced shortly are 3 more new titles. We're also introducing the MSc in the specialist clinical practice of aesthetic non-surgical interventions. This is to do with facial cosmetics. The MSc in the specialist practice of computer-guided implantology. This is implantology taught from a digital perspective. Also a combined MSc of restorative aesthetic dentistry with implantology. These programs are all taught from our laboratories where hand-on experience is required, where delegates get the opportunity to use the latest digital equipment, printing materials, scanners, and also to practice prep techniques on phantoms. Our short programs are in topics such as implantology, restorative and orthodontics. These programs normally last anywhere between 4 to 12 months. We also offer clinical internships in the UK and the UAE, where delegates get to treat patients directly. In addition to this, we offer diploma and certificate programs. These programs are at HE level 7, so they're university certificates, which means that they can be used towards MSc programs, not just MSc programs that are offered by the City of London, but also other programs. So thank you for sparing the time to listen to this presentation. If you want any more information, then please contact us at info@cityoflondondentalschool.co.uk. I hope you enjoy your presentation today.
Now in the UK, the organisation that helps set the standards, and these are the standards that we're expected to work to by the GDC. They've co-authored these standards in combination with the faculty, Royal College of Surgeons. So if you're a UK practicing dentist, these are the regulations to which you will be held to. And these were published, the latest set were published in 2016. Before that, there was a set of regulations which were published in 2012. And the new set of regulations are quite a bit different to the previous 2012. But the interesting thing is that this particular requirement is in the previous regulations or standards and is also in the new set of 2016. And interestingly, there's supposed to be another set published in 2020, but normally they seem to be about 2 to 3 years behind themselves on publishing these things. So I dare say that these regulations are going to be in place for the next 3 or 4 years. So most importantly for us is that anything we do should be evidence informed. It should be based on evidence. And it must be obviously in the patient's best interests. And this is very important to take on board because we get stuff through the post every day, information telling us about the wonderful new techniques and protocols. And we need to, if we're going to use those in our practices, we need to be able to show that we've at least done some investigation of the evidence that's underpinning this new technique or material. The other thing that's still in the regulations from the older regulations is the clinician should take responsibility for assessing the effects of any implant features. In other words, if your implant has some new wonderful coating or some new interface or new abutment that's very radical and very different, well, I'm not saying that that isn't a wonderful development, but remember, at the end of the day, you take liability, ultimate responsibility for placing that device. And if the company's at fault, well, they can go bankrupt, they can stop trading. Unfortunately, you'll be left with the responsibility for the patient's ongoing treatment and remedial treatment that might be needed. And there's quite a few implant companies, little companies, that have gone bust. And one of the requirements here is that you need to make sure that whoever's supplying your implant materials is sufficiently stable and of adequate stature to be able to provide components and parts for the foreseeable future. So not only are you responsible for the evidence that's for whatever you're doing, you're also responsible for the design features of whatever you're using. You're also responsible for ensuring that for the next 20 or 30 years, that there's every likelihood that you'll be able to get components to be able to restore or treat those patients going forward. And I, in my practice, are certainly seeing more and more people coming with old types of design, and it's getting very, very difficult to restore these implants because we just don't have the components anymore. Now, remember that osseointegration was first pioneered by Professor Brannemark, and this was in 1952. He first coined the term osseointegration. As I say, this particular diagram works on a number of levels, and it sums up the whole of implantology in one go, right? This is everything you need to know about osseointegration from every level, from risk management, from consent issues, from whether you should be using an implant or not, all the things that will affect osseointegration. So we start at the very top with our host and general health factors, and we'll be looking a little bit about that as we go forward. We look at things like implant design and materials. We know about bone quality and quantity, and then we look at our surgical and restorative protocols. And all these headings, if you like, all these points will all have an effect on our osseointegration, and they are all interlinked. So all these 4 topics, all you have to remember, these 4 topics, they're all interlinked. They will all have an influence on osseointegration. Now, I teach implantology, and one of the questions I'm always asked at some stage from a student who looks very surprised and says, "Why did my implant fail?" And the first point is, if you do implantology, you will get failures. There's no avoiding failures. Everybody that does implants has failures. And you can reflect on the reason for the failures and try and work out what you think the reason is, or it may be there was a combination of reasons. It may not be one failure. It may not be one particular factor. It's sometimes multifactorial. So when we look at this cycle, first of all, we have the host and general health factors. Can we affect that? Well, no. Often we have to accept the patient's general health that they come in. Maybe 1 or 2 things are manageable, but we have to accept that. That is really outside of our control to a large extent. It's not in our direct control. You can see at the bottom of the state, I've got direct and indirect control. So the health issues aren't in our control, but we can influence it, and we can assess it, and we can manage it. So there are going to be some individuals who, for general health reasons, aren't good implant candidates. Yeah. Implant design and material, and that is in our direct control. We're responsible, as I've said, for selecting the implant, the design, the materials. That's in our direct control. That we have an influence over. But if we have a patient with poor bone or is unhealthy, it doesn't matter really how good your implant is. It doesn't matter if you purchase the most expensive Mercedes brand of implant in the world. If you've got a host that has poor quality bone, poor quantity bone, or poor general health, it really doesn't matter. This whole process of osseointegration is about osseo, bone, and bone integrating onto the surface of your implant or attaching to the surface of your implant. So it's about the bone's response. And really the implant, yes, it's an important part of it, but if any of the other factors are wrong, it doesn't matter about your implant design. But dentists do tend to get fixated on a particular implant or a design feature because they've been sold this by the manufacturers or the distributors, and they focused on one thing and they ignore all the other things, and they think, well, I can put this implant in virtually anybody. It doesn't matter how much bone I've got. I don't have to worry about the bone quality and quantity. I can restore it any way I want. I can immediately load it. I can put it into no bone. I can put it into fresh air. Now, these are all outside of the implant design. Yes, implant design is important. We have direct control over which implants we buy, which type of restorative components we have direct control over. Bone quality and quantity, yes, we can influence them by doing things like bone grafting, using membranes. We can influence them, we can try and improve them. Is that predictable? Is grafting predictable? Are you going to generate the bone you want or the quality you want in 100% of your cases? You know, that's a big question mark. That's not so much in our control. We can try to influence it, but it's not in our direct control. Now, we move on to surgical and restorative protocols. Now, these will have an effect to certain degrees on our implant success and also perhaps the long-term success and treatment outcomes. And you might be deciding to do early loading, immediate loading, or you might be doing immediate implant placement, which is surgical. So we've got these different surgical protocols, and that's in our direct control. Are those surgical protocols applicable to every person that walks in the door, or should you have a variety of surgical protocols and approaches depending on host factors and their bone quality and quantity? So you can see all these are interlinked factors. Each one of them you could probably run an independent course on, just on its own. But as I say today, we can only briefly look at each one, and I'm going to flag up perhaps some of the main points you may or may not be aware of. Now, we've gone through this, but this cycle also looks at risk, because obviously somebody who's poor health, they're going to be at higher risk of failure. Somebody who has poor bone and quality, that's going to be at higher risk of failure. Maybe if you're doing a very advanced restorative technique or surgical techniques, they have more chance of complications. So you can see it's also not just looking at the factors that affect osseointegration, but it's also looking at risk. So when you're assessing the risk of something, have these 4 headings again. When you're assessing whether osseointegration will work and what you need to do, consider these 4 headings. And finally, this all leads through to consent, because part of consent is that you need to be able to inform your patients of the risks and benefits associated with the treatment. Now, most of the dentists are very good at clarifying what all the benefits of the treatment are, and they're very enthusiastic to get patients on board for implant treatment. One of the things that we're perhaps not so good at is actually pointing out to the patients what the risks are, and in particular what their influence is over treatment. And this brings us to the maintenance requirements, because obviously more expensive, more elaborate, multi-implant restorations, these are going to need more maintenance. If you have some host factors there, they're going to need more maintenance. And that has to be brought into your consent, because placing an implant is an elective procedure. So if you do these things and later on the patient loses all their implants for one reason or another, and you say, well, they didn't come back for maintenance and they had to come back every 3-4 months and have this checked and that checked. If you haven't specified what their maintenance requirements are in your consent, well, then that's not informed consent, because they need to understand what their requirements are. It's no use saying, well, you know, you should have come every 6 months, Mrs. So-and-so, for your implant checkup, and you haven't done it. And if she says, well, nobody ever told me, and when you sold it to me, you said implants would last my lifetime, and now they're all failing because of peri-implantitis, and you never said I had to come back every 6 months, and where does it say that? This is where you will come unstuck long term. So please look at this cycle, these 4 things, and I'm going to go through each one, flag up the ones that I think salient points of each one, and we do cover this in more detail in our courses going forward. So, host general health. Now there's a whole myriad of conditions, diabetes, osteoporosis. I'm not going to go into any of that lot. When it comes to medical conditions and host things, I'm just going to focus on what I feel is most likely to come in through the door. You know, you can come up with things like Paget's disease and these weird and wonderful syndromes that affect our bone metabolism, right? You can, all day long. Again, you can have a whole year's MSc course on that if you wanted to. But what are we as general practitioners? What's the most likely type of person that's going to come through our door? What are they going to be taking that's going to have a serious effect on our outcome and our chances of getting this osseointegration? Well, the most important thing to remember about general health is it determines the biological quality of the bone. So most times when we're doing a general medical history, we're doing it to check that really they're going to survive our treatment and they're suitable for treatment, and that we're not going to do anything that's going to somehow influence their treatment or their medications that they're on. So that's what we want to do. We want to know they're healthy for treatment. But the other thing with implantology is, obviously it's important to know they're healthy for treatment, but it's also important to assess the bone quality, the biological quality. Now, most implantologists, when we talk about quality, we think of mechanical quality because that's important for primary fixation. But there's also biological quality, which is important for secondary fixation, which is that biological process where the bone attaches to the surface of the implant. That's very much dependent on the host's general health. And we know things like diabetes or osteoporosis will affect and influence the quality of that attachment. It may not be clinically significant, but we know about these things. The other thing about our, when we look at general health, again, that is overlooked, and I put it into this because for some unknown reason in dentistry, we always separate oral health from general health as if, oh, fantastic mouth, but the rest of you is terrible. Actually, oral health is part of general health and shouldn't be stuck out there on some sort of limb. All right, but it's the way we tend to look at it. But I'm going to bring it into a host general health, and I'm going to be looking at their periodontal history and of disease and treatment. So I'm looking at the most common type of things we've got. The medical history is done to look and try and work out the biological quality of our bone, its metabolic quality, if you like, its healing potential. That's what we want to know from our medical history. And finally, the age. We all know that as we get older, and I don't include myself in this group, but as everybody else gets older, our healing potential tends to fall off. It takes longer for bones to heal. If an elderly person breaks a bone, it's going to take quite a lot longer, and they may have more complications with their healing than somebody who's young, fit, and healthy. So bear in mind that, you know, elderly people, you may need to give them a little bit longer for their osseointegration to really take effect and kick in. So this thing about what is the most likely things to be affecting us in general practice. Well, there's been some recent developments on these things called selective serotonin reuptake inhibitors. Now, they're a first-line antidepressant, and they're prescribed quite heavily. They're the most frequently prescribed antidepressant in the UK. And the reason what they do is they low levels of serotonin are implicated in the cause of depression. So if you block the reuptake of serotonin at the synaptic junction, the idea is that this will make the patient a bit more happier and less depressed because you're increasing the level of serotonin at the synaptic gap. But interestingly enough, it's associated with lower bone mineral density. And it suggested that serotonin receptors found on osteocytes and osteoblasts and osteoclasts can be activated by the serotonin selective reuptake inhibitors. So they have an effect on bone metabolism. They increase osteoclastic activity, leading to bone loss, and implants placed in patients with a history of depression seem to be more prone to failures. Now, one of the questions on my medical form, which may not be on yours, is, are you taking any antidepressants? Have you been treated for depression? Now, this works on several levels. One, it gives me an idea maybe of the psychological mix of the person I'm treating, what they're like, because, you know, do I really want to take somebody on with some psychological conditions that I can't manage? But also, if they've been taking these drugs and are taking these drugs, they may influence the success. Now, they found that people who are on these things have got 3 times greater risk of implant failure, or, you know, greater odds of implant failure than people who haven't had them. Patients who are on these things were found to be 3 times more likely to experience an early failure, right? So if you get, you know, basically somebody that's going to get an early failure 3 times more likely. One paper came up with 12.5% for serotonin reuptake users as compared to 3.3 for none. So that's quite a significant, you know, as I say, there's 3 times more likelihood of them getting a failure. So does that mean I won't treat them? No, it doesn't mean I won't treat them. But it may mean that in my consent letter, I say something along the lines like, oh, you know, recent research shows that there might be a link between your antidepressants and implant failure. Now, that may or may not be significant. And the research sometimes says, oh, it's not clinically significant. Well, that's all very well and good. But the law and the law on consent takes a different view of what is significant. And it's not what's clinically significant to us, it's what's significant to the patient. And if the patient later finds out that they had some implant failures and somebody points out, well, this may have been related to your taking antidepressants, and if they then turn around and say, well, if I'd known that, I wouldn't have had the implant, you might turn around and say, well, the papers say it's not clinically significant. Well, the law says if it's significant to the individual, then they should know about it. And also, it helps out if you do get a failure and it's in your consent letter, patients are perhaps more willing to accept it than otherwise would be the case of you explaining something at the end of the day. So the type of inhibitor dosage is, and host-related genetic and metabolic factors could be modulating factors in this, so it's not a direct causative thing. There's other things that come in, what dose, the length of time, general health. And there's little data actually regarding this at the moment. It's a very new thing, but we do know that it may be important in our older cohorts of patients, And many of these individuals may well be the ones that are taking these things for depression. Superimposed on this may be other medical conditions or age-related conditions that affect the biological quality of the bone. Now, there was this paper published in 2016, and one of the authors of this paper is Albrechtsen. Now, Albrechtsen was one of the pioneers of implantology. He actually wrote down the criteria and published the criteria for implant success. Now, these criteria have been tinkered with and modified over the years because as new techniques have come along, the success criteria have changed. So either way, he's a person that's to be respected. His opinion carries a lot of weight. So anything that's published by this gentleman needs serious consideration. Now, he looked at 642 implants that were placed between 1980 and 2014. So that's 34 years of data. And they found that 6.36% failure rate, which isn't too bad. And they found that 1.7% were lost up to second stage. So these were early failures. So if I want to round this up, I can say 2% of failures are going to occur early, and maybe 4% are going to occur over the next 20 years. And this is what you tend to find. People do get late failures. Again, this may occur for a number of reasons. Most commonly in my practice, it seems to occur because their general health changes, yeah? So this tends to be a reason for failure. So the distribution of implants in sites of different bone qualities and quantities was quite similar, and implant loss up to connecting the abutment. Now, we, in the early days of implantology, we thought that the failure rates, or the data showed us that the failure rate was to be expected to be higher in the posterior jaws, particularly the posterior maxilla, followed by the posterior mandible, followed by the anterior maxilla, followed finally by the anterior mandible, which had the highest, if you like, chance of success. So we had this in our mind that we had these regions. Now, it seems that these regions aren't so important now, and the success rates seem to be about equal in all the regions. And this is probably due to a combination, I think, of improved surgical techniques and perhaps improved implant designs. So that's a thing that we've directly influenced through our direct actions, if you like. That's something we have a direct control over. We don't always have a direct control over which sites we can place our implants. Now, what he came up with at the end of this was smoking and the intake of antidepressants were the significant predictors. So basically, those things were the things that really indicated whether we were going to get these failures, early failures. So it's worth taking on board from this lecture. Look at antidepressants, and then this combined with smoking is a serious indicator that you could be lining yourself up for failures. And again, am I saying don't treat these people? No, I'm saying make this clear to them in the consent letter that given their social habits and the antidepressants, they should expect higher failures. And even in those individuals say, look, you have to stop smoking before I place any implants in you, because a combination of your antidepressants and smoking isn't going to help our implant treatment. So be aware of the potential association between this antidepressant and implant failures. And there are more studies to check this all up and confirm exactly the influence that these things have on our bone attachment, right? But this all has to be studied later on. More studies are needed, but there's enough evidence out there to at least start the sort of alarm lights flashing. So there's implant design, features and material. Again, we haven't got the time in this presentation to go through any of this in any kind of detail, but we do know we can look at implants in terms of their gross design, which is whether they're tapered, cylindrical, the thread form. We can look at the abutment, how the abutment connects. Now, these gross features will affect things like marginal bone loss, stability. They will affect whether we can use immediate loading protocols, immediate placement protocols. Do they prevent us from using any of these designs in any immediate loading? No, you can use cylinders for immediate loading if you wish, but it's probably a little bit harder to manipulate, and it's harder to develop good primary fixation as compared to tapers. So you can see how the design of our implant will influence the type of protocols we can provide. Then we look at the microscopic design, and people go on a lot about surface characteristics. That's very important. And finally, we're looking at the material, which is nowadays is a big move towards ceramic implants. I'm not too sure why and what the advantages of ceramic implants are. People say things like they're more aesthetic, but they're in bone, so I can't see what color the implant has to do with that, but maybe we'll look into that. But bear in mind that the GDC will be looking at your reasons for the design choice and material choice of the implant. And if you place ceramic implants, and after 5 years, you get a lot of fractures or complications, and then you go back to the people that have supplied them and they're no longer around, well, you'll be the one that's carrying the can, and you'll be the one that be expected to explain why you chose those implants and on what grounds and what evidence and what clinical trials. So again, you know, if you're going to use some different kind of material, make sure that there's a good background of evidence behind it. Nobody's going to really throw stones at you if you've used titanium. Titanium's been used in the medical grade titanium's been used in hip replacements, and it's been around for medical device use for like 100 years. So the safety record, our knowledge on the material from orthopedics is extensive. So nobody's going to have a problem with that. But if you're looking at things like surface characteristics and changes in materials, as I say, be very, very careful. Now, there's a lot of information out there on surface roughness. Again, this is a whole thesis on its own. This is a whole different thing. We could attend a whole lecture on just surfaces alone. What do we know? Well, we know that a rough surface promotes bone attachment. We get earlier integration. Different manufacturers will say different things and make different claims for their surfaces. They want to sell their implants. They will show you lots of slides and everything else, but at the end of the day, we want a rough surface, and we don't know exactly how rough is good or bad. We've got, I would like to say a rough idea, but that would be a pun. But we have a general idea of the sort of roughness we need. These surfaces can be produced by about probably 20 different combinations of techniques. All of them seem appropriate and successful and deliver a good surface with a high surface energy. Now, we want a surface at high surface energy so that we get good protein absorption onto the surface of our implants. And that's why whatever process is used to manufacture the implant, we want to have a clean surface at the end of it. When we look at that under the electron microscope, we don't want to see lots of little bits of carbon and other material left over from the manufacturing process. And you'd be surprised at just how many implants have got quite dirty surfaces. And some of them are from the quite reputable, well-known manufacturers. And when you look at their surfaces under the electron microscope, they're covered in debris. And every spot on that surface of that implant that's covered with a bit of carbon or leftover oil or whatever in the manufacturing process, or maybe different material, those are potential areas where you will not get attachment. So the dirtier your implant is, the less the surface area there is for attachment. And so you can have all the other things right, good host, good bone quality, and you're using an implant with a poor standard of cleanly surface. Rough surface, well, we can debate on which surface is good and which surface is bad. There's no strong evidence. At the end of the day, we want to have a surface that's clean, that will allow protein absorption, a formation of what we call a sort of glycoprotein layer to attach to that surface of the implant, so that then the osteoblasts can get into intimate contact with the implant, and they can proliferate and they can differentiate and go on to produce mature load-bearing bone. That's what we want. And maybe if you're going to be using short implants, these types of considerations take on more significance. Bone quality and quantity. Well, we can affect those by grafting techniques and by the use of membranes. But just as we have different types of implant designs, different types of cleaning process on our implants that will affect how they osseointegrate, there are a myriad of different graft materials out there on the market. And there's different types of graft materials. There's autografts from the patient, there's allograft, which comes from other sources, human sources, there's xenografts, which come from animals, and the synthetic graft materials. They all have different properties, they all have their advantages and indications and contraindications. And again, if you're going to be using grafting materials, it's important for you to understand where they come from and actually have read perhaps their instructions for use. Now, this is quite interesting in that you pick up some graft materials and you read their instructions for use, and they don't mention anything about being used next to an implant. So there's some graft materials that actually were developed for periodontal treatments. Now, that doesn't mean to say you can't use them next to an implant, because you're allowed to use what they call off-label. As doctors, you are permitted to use products off-label. So it's not for the direct instructions for use. But remember that if you're going to use a product off-label for something that it wasn't originally intended for or placed on the market to do, then if subsequently there's a problem related to that, you again are on your own, because you've made a decision and you'll be asked to justify why you use that product off-label. And it might well be that thousands of other dentists use that product off-label in the same way, in which case it's completely permissible to do that, because you can say, well, hundreds of colleagues and the dental profession use this graft material for this purpose. That's okay, and it's off-label. But if you're using something off-label in a really unusual way, or it's a very new product that hasn't been properly researched and supported, and you've bought it cheap from some supplier on the internet from God knows where, and then there's a subsequent problem or a graft fails, well, again, the person reviewing that case could say, well, this graft material you've used, I've not come across the name, and I've researched it and I found out the company's gone bust and this, that, and the other. And then again, you are responsible. So find out the graft material and what it delivers. Also, if you use a graft material inadvisedly and in a situation where it will not generate new bone, then again, you're liable. If you use a graft material that wasn't designed to produce bone in that way, and then it subsequently doesn't produce bone, and the patient decides to take this further, and you use the graft material in a way that was guaranteed to not lead to a success, then again, you have problems. And very often, I see cases where dentists have tried to increase ridge height by using particulate hydroxyapatite materials, for example. And it's very difficult to increase height around implants at the best of times. But then if you're using the wrong materials, it's even less likely that you're going to get the result you want. And if the patient then subsequently has failures or complications, you of course will have to explain why you selected that material, why you used it. Was it osteoconductive? Was it inductive? What were the properties of that material? Again, when we're looking at bone, the patient's host bone, autogenous bone, that is always considered to be the gold standard, the absolute best bone you can use. But remember, depending on where you're getting your bone from, it could be hip bone, chin bone, wherever, you have a bone that's come from bone that was formed through intramembranous ossification, which is the majority of the skull bones. And those of you who think back, we also have bone that came from endochondral ossification, such as the base of the skull, but more normally you look at the long bones. And these types of bone have different resorption rates, and these types of bone are more indicated for certain situations. So the donor site that you select is very important to perhaps the outcome to the graft, and also long term, because you may get an increase in the bulk of your ridge. You may improve the height slightly. You may get all these things. But if in 3 to 4 years' time it's all gone because the bone has resorbed, then really what use has it been? So just bear this in mind. Just because you take autogenous bone and it's the best bone in the world, these bones do have different resorption rates, and their stability is different as well. So when you're going to use autogenous bone, bear that in mind. We do know these things resorb at different rates. Now, often the places we use bone grafts are, and the popular one, which some of you may be involved with, is sinus lift procedures. Now, maybe 10 years ago, I used to do a lot of sinus lift procedures. I do far fewer now, although I do note that the incidence of sinus lifting being carried out in general practice is going up, because as more dentists place more implants, there's going to be demands on them to place them in the posterior maxilla. The bone will be limited, and they will be considering, or if not, they will be doing sinus lifting in order to place longer implants. But again, if we look at this meta-analysis of, and now this is single crowns supported by short implants which are less than 10 millimeters in the posterior region. And they looked at 700 odd implants, and they were followed up over 120 months. Now, when you're looking at papers, and this is the evidence thing, one of the things is look at how long these things were covered up. How long they were followed up for, or maybe covered up for. If they were only over a few years, really, I would be very, very, very cautious about using that as evidence. Also, what sort of trial was it? If it's a case report which somebody's written about a new technique, that's very interesting. But remember, it is only a manual. It's not an article, it's not a research. It's just somebody writing up how they're using something, and it's a manual, it's a report. It is a case report. It doesn't even have to be referenced particularly. It can have just a bibliography of other manuals that were used to compile the report. So it's a very low types of evidence. It can be very useful as a technical manual in giving you tips on how to use something, but it is not evidence that that is a good product or that you should be using it. So the follow-up period was quite good. It was 44 to 30 odd months. And the other thing that sometimes isn't mentioned in reports is the dropout rate. Now, that is the number of people that never got to the end of anything. They just dropped out. Now, if that dropout rate was quite high, and it's approaching quite high at 5, because it means that out of those 762 odd things that were placed, something like 35 or 40 of them were patients who never returned for follow-up. So we don't know why they never returned, because they never follow up why they didn't come back for their appointment. And it may be that all 36, if you like, had failures. And so they thought, oh, well, this has failed, I can't be bothered to go back. Now, if you put those failures back into the pool for your success rate, obviously your success rate is going to go down. Your survival rate is going to go down. So the higher that dropout rate, if they mention it, the more you need to know. And unfortunately, a lot of papers do not take into account the dropout rates to their studies. Now, the conclusion from this was they had low failure proportions, about 6%. I don't know if I really think that that's that low, but the paper thought it was, I'd rather see about 3%, I think. Low incidence of biological complications, low prosthetic complications. And remember, these are low prosthetic complications over the 120 months. And the follow-up time as well, which is like 3 years. Minimal bone loss are reported after a mean follow-up period of, say, 40 to 33 months. So all in well, this is looking very interesting for small length implants in the posterior maxilla. And remember, this is a paper for single tooth implants. Maybe this would be a higher failure rate or a higher success rate, we don't know, if it was used for multiple restorations. So they also came up with it, and this is interesting because it's completely the opposite to what I would have thought in terms of bone quality, mechanical quality. Implants supported by shorter implants in the maxilla has a better prognosis over the mandible. So they found, or their conclusion was, that these things work better in the maxilla than the mandible, which is quite unfortunate really, because it's harder to graft the mandible than the maxilla, and it would have been nice if it was the other way around. But again, it's interesting, and one can speculate why that may be, that they found the prognosis was reduced. They didn't really go into any details on the paper. And again, that's sometimes an unfortunate thing with the papers, is that they don't actually give any great details about the failures. They just say, oh, we had 5% failure or 10% failure, whatever. They don't actually explain what the failures were and why they thought they failed, which they all go on about the success. We had a 95% success rate. I would like to know more why it went wrong and how we can get that failure rate to shrink it even down further. So we need to look at the failures more closely. Interestingly enough, surface topography did not affect the failure proportion and incidence of biological complications of short implants. So again, they're putting a question mark whether all these design features and these wonderful different surfaces have any real effect on the prognosis for our implants long term. The surgical handling of the recipient site is critical for short implants and implant stability. So yes, we can see that if you haven't got much bone and your surgical protocol is rather drastic and not preservative of soft tissue, of hard tissue, and removes a lot of hard tissue, maybe you're countersinking because of the implant design, maybe you're having to remove a lot of bone, for whatever reason, you don't get good primary stability. You're already at a disadvantage because you've got limited bone to provide primary stability. Then on top of that, you have a surgical protocol that doesn't predispose to trying to increase the primary stability you can get from that bone, that limited bone. Then if you superimpose in that perhaps some ambitious treatment plans where you want to immediately load that short implant, and let's suppose that short implant is a terminal implant, that means it's at the end of the arch, so there's no other teeth behind it. And let's suppose that implant is put into a person who's a bruxist, then you can see that that failure rate will be a lot higher. And sometimes in these documents, they don't really go into any details about how they selected the patients. So they should be saying things like, it had to be an implant with contact points either side, it had to be in a non-bruxist, it had to be in a well-maintained occlusion. There could be lots of things that they had, their inclusion criteria for these researches. Now, again, when we take this data and we take it out into general practice, it tends to be applied without any kind of filter. All right, short implants work, so now I'm going to use short implants all over the place. Well, no, short implants will work, I'm sure, in carefully selected and assessed cases. And it comes back to that cycle again, where you have the host, general health, you have the design of the implant, you have the bone quality and quantity, and you have your surgical and restorative protocol. And you've got to apply that cycle to everything you're doing. Not just think, oh, I can use a short implant anywhere now because the paper says I can use it anywhere. You have to put some thought. So, interesting enough, they did not find that an increased crown implant ratio of a shorter implant supporting single crowns did not influence the marginal bone loss, and not associated with increased implant failure rates and occurrence of technical complications. So basically, from our crown and bridge work, we always worry about the crown root ratio. It seems that crown root ratio isn't such a big deal when it comes to implants, and there are quite a few papers out there that do reach the same sort of conclusion, that crown implant ratio aren't as significant as we might think they are from our dental knowledge of the natural dentition. Right. This is a very interesting one. The influence of exposing dental implants into the sinus cavity on survival and complication rates. And this is a systematic review. Now, the nice thing about systematic reviews is they do give you the highest value of evidence. So if you're looking at evidence and patient-centered approach as is required, these are the papers you should be relying upon, you should be looking at, you should be keeping in your back pocket, because these are the ones, and also newer ones. Like you can see the publication date here was 2019. Obviously, if it was a systematic review conducted in 2012, that may not seem that far away, but in fact, it's nearly what, 7 odd years, away. I think somebody's managed to put their microphone on. Okay. So basically, these are projecting, these are implants projecting into the sinus, and we don't like the idea of implants perforating our sinus membranes. So sinus membrane perforation represents the most common complication. And in things like sinus lifts, it's running at maybe, say, 5 to 6% of sinus lifts. You will perforate, and when you're lifting the membrane, and that doesn't go for undiagnosed ones, which I reckon are probably running at even higher, and it might be more like even 40% small micro tears. So sinus membrane perforation is a very common, and in fact the most common complication we have in this region of the mouth. And the aim of this review was to determine the relevance of this phenomenon on implant survival and complications, because one of the things we're concerned about is if we perforate the sinus, if we go into the sinus, what will be the problems for us and the patient. So when we look at the graphic representation of implants intruding into the sinuses, we've got this situation, which is on the left-hand side, where we've elevated the membrane slightly, and we've inserted the implant under the membrane. And this is reported in the Brannemark early stuff, and this was considered acceptable. And the idea is we get a little bit of a blood clot forming around the apex of the implant in this area here. We get a blood clot forming, and this then later undergoes ossification, and we get bone forming around the apex of the implant. And the membrane obviously being intact means you haven't invaded the sinus. But then we get the implant actually perforating that membrane, ripping that membrane, and protruding into our sinus. Right. So as I said, as complications, it's the most frequent clinical complication, and that it's associated with nose bleeding. Sometimes those experienced implant guys, when you place implants in the maxilla, the patient has a slight nosebleed afterwards. But they did find that if patients did get this epitaxis, that the level of perforation wasn't influential on how severe it was or the amount of bleeding they suffered. Just if you got a membrane perforation, likelihood is you've perforated the membrane. So the most common radiographic complication was thickening of the Schneiderian membrane. So radiographically, when we perforate the sinus, one of the complications that can happen is, apart from a reactive sinusitis, of course, but the most common radiographic one is going to be this thickening of your Schneiderian membrane. Now, the Schneiderian membrane is the membrane that actually lines your sinuses, and it's named after, I think, some Austrian who was the first one to actually is an anatomist, and he was the first one, anatomist, sorry, and he was the first one to actually define and write up and describe this membrane. Right, so most frequent radiographic complication was this thickening of the membrane. And what they found was that about 5%, you got 5% of cases with thickening or showing thickening if the implant was perforating by less than 4 millimeters. However, if the implant was perforating more than 4 millimeters, it was 29.3%. And this was considered not to be significant statistically. So this is the situation. We've got two groups here. We have one group where the implant is now perforated and ripped the sinus and is going into the sinus by 4 millimeters. And we have another group where it's actually gone beyond. It could be 4, 6, 7 millimeters, we don't know. On this particular one, this diagram, it's showing, if we look at the little measurer, they've said that it's gone through about 6 millimeters. So this is a situation which would alarm many of you. You wouldn't like to see this happening around your implants. But the conclusions of this paper was exposure of dental implants in the sinus cavity without augmentation procedure or graft materials shows a high survival rate. 95% of them still survived. So the fact that you actually perforated the sinus membrane didn't affect the survival rate. These things went on and survived and functioned at 95.6%. And there was no statistically significant differences according to the level of perforation of either the lower or the higher implants. So it doesn't seem, on the basis of this systematic review, which would have been looking at many thousands of papers, grading, assessing them, it doesn't seem from the literature that there's anything to show that actually popping an implant into the sinus by 4 to 5 millimeters has any effect whatsoever on the survival of our implants. And so those amongst you might be thinking, haha, I don't need to worry about short implants now. I'll just get a load of 10s and 12s, and it doesn't really matter if I perforate into the sinus, and because this paper shows the implants are going to work all okay, so I don't need to worry going forward. Now, that is perhaps over extrapolating what this paper is saying. This paper also says there's thickening of the Schneiderian membrane. This paper doesn't go into any details about long-term problems from the sinus. It doesn't mention the complications of sinusitis or reactive sinusitis following membrane perforation. So we have to look at it carefully, the evidence, what it's saying and what it's not saying. So just applying it and saying, right, we can now quite happily stick all our implants into the sinus and we don't need to worry about it because of this paper. That's not what it's saying. It's saying the implants will function, but we don't know what effect that's having on sinus function. and later on whether that patient will go on to develop even a chronic sinusitis. We don't know from this paper. So yes, I think it's best not to go anywhere near the sinus or limit how far you go into it, but it's not going to have an effect on our implant survival rate. That's what this paper is saying. And some of you may be using or involved with zygomatic implants, and some of these transverse the sinus and actually go one side of the sinus and come out the other side. And what they have found in some of the more recent papers is that these individuals have a very much more thickened sinus membrane, and some of them are developing chronic sinusitis problems later on. And these are going to have to be managed. And if you're thinking of using them, maybe one of the things in your consent letter should be about sinusitis and the possibility they could have more sinus problems later on that need to be managed. So surgical and restorative protocols. Remember the cycle, we had the general health of the patient, and we had the implant design, and we looked at bone quality and quantity. And I'm going to say a little bit now about the surgical and placement protocols. Now, there is lots of things on surgical placement protocols out there in the literature. There is lots of different loading protocols. There are lots of different restorative protocols. All of them have their advantages and their disadvantages. But the one thing that's common to all of them is they represent a paradigm shift. And what do I mean by this? Well, what I mean by this is the original work, and we looked at Professor Brannemark from 1952, that original work and the papers that he published on osseointegration were based on very firm rules and regulations, and you followed these almost like a religion. And all the research, all the implants were placed into basal bone, not alveolar bone. Dentists started placing implants between teeth into alveolar bone in about the early 90s. Initially, it was only edentulous and full arches, right? Next thing, there was no such thing as early loading. These implants were always submerged and always left at least 4 to 6 months before any kind of loading was carried out in order to let it was so firm, in fact, that they wouldn't let the patients wear their dentures for like 2 to 4 weeks following the procedures. The patients had to live on mashed potato and porridge. They couldn't load these implants at all. And the restorative protocol was quite involved, and these things were restored using gold frameworks and plastic denture teeth on top of the gold framework. The reason for the plastic teeth was because they thought it limited the amount of loading on the implants. Things like using porcelain were actually contraindicated, and the thought of using porcelain would have been a dreadful thing to suggest. And all these changes, or all these different changes, will have long-term maintenance implications. So this slide is just saying all these things are changing. They're going to carry on changing. They're going to carry on evolving. They are very different to what the original protocol was. It's like a 180-degree shift. Well, that'd be taking you back, 180-degree shift. Perhaps we'll go 360 and be back to the older protocols at the end of the next 10-year cycle, when people have got problems from what they're doing now. There'll probably be a shift back, I'm sure, to some of the earlier protocols. The main thing about protocols and risk is you, as an implant dentist, are crossing a great big cavern. This is multifactorial risk factors going on. Host factors, loading factors, bone factors, all these things going on. You want to have the greatest chance of success. You want to make sure you get to the other side in the safest way possible. If you do very adventurous and dangerous protocols, the chances of you falling off the rope are very, very high, right? Or you can follow more predictable protocols and be on the safe side. And it's entirely up to you which one you want to take. But either way, if you fall off that rope, you're going to be the one that gets injured. Okay, your patients will also be injured, but you're the one that's going to take the can. You're the one responsible for walking across that thin rope, rather than taking your patient, who's the elephant here, across the nice, easy, predictable pathway. So by all means, use the most elaborate protocols you want. Perfectly permissible. The evidence shows that all these protocols have high success rates. All the systematic reviews show that they all have good success rates. What they don't often go into is they don't look at the experience of the person doing them. So if you're a novice dentist who's placed less than, say, 10 to 20 implants, and you're going to start launching into full mouth immediate loading cases, you can expect high failure rates, regardless of what the papers say, because you're on a learning curve. If you're an experienced who's placed probably 50 or more implants over quite a long period, is quite comfortable with different protocols, then perhaps shifting up a gear and increasing your abilities, that's probably a safer way to go. Now, again, when it comes to medico-legal situations, if I was a GDC, and I know the GDC, they'd be looking at training. They'll be looking at experience, and they'll be saying, okay, doctor, you've done some, how many implants have you placed? Oh, 4. Where did you get the training? I did an internet course, and I did a couple of lectures, and I did a course by the manufacturer, who's now gone bust. Okay, fair enough. So did that. Where's your training records? How many did you place? Oh, have you done this immediate loading before? Have you done it? No, this is my first case. Oh, what training? Oh, I didn't know. They do that many. Who supervised you? Oh, I didn't know. And you can see that you'd be getting yourself into a lot of trouble. So if you're a novice and you haven't been placing implants for a good long while, moving on to things like early loading, grafting procedures, really moving outside the scope of your training. Your first 5 years training did not prepare you for immediate loading of implants. Did not perhaps prepare you to actually read and assess CBCTs. So if you're relying on a CBCT and your technician to plan the case for you, then again, you're walking on that tightrope, because ultimately it's you that's going to fall over the edge, not anybody else. So another surgical protocol we can look at is site preparation. And we have the conventional following our drilling protocol, or there's other protocols where we can undersize. There's other protocols where we can do osteodentification, and that can be done with hand instruments. It can be done with rotary instruments. There's all ways that you can achieve site preparation. And the main thing with site preparation is we want to do techniques that will in some way improve or get us better primary fixation. Now, it doesn't matter which one you use, it's what works best in your hands. The papers are very divided on what's good, what's bad when you read them. All we can say really is we like primary fixation, because that's been shown to have an influence on the successful osseointegration. If you want to do any form of immediate loading, you'll require primary fixation for the bone to be able to take the loading of the implants. So that's what the surgical technique can influence, that primary fixation. And if you get poor primary fixation for whatever reason, then you're best off doing a delayed protocol and covering that implant up. And that's another thing, if you're offering a patient immediate loading protocols in the consent letter, I think it's very wise to say, and if on the day we find we can't get good primary fixation, we will have to do a delayed procedure. End of story. But if you've sold them, oh, they're going to get teeth in a day, and then they don't come out with teeth in a day, you're going to be upset and say, well, sorry, the bone wasn't that good. And the patient will turn around and say, well, why didn't you assess the bone? And why didn't you tell me the bone wasn't that good? and you promised me this would happen. You never said I'd have to wear dentures. In fact, I only did this whole procedure because I didn't want to wear dentures. And now, thank you very much, I'm wearing dentures and I've become edentulous. So you've removed all my periodontal teeth and you've given me a set of dentures, which is what I didn't want. So you can see you're in a really deep water. So this was a review, a systematic review of published papers on primary stability attained using the osteodensification drilling technique. And it looked at things like the bone implant contact and the fraction of the area of the threads occupied by the bone. So it looked at a number of things, primary stability and the intimacy, if you like, of your bone contact. And the conclusion of this was an average increase in insertion technique was found, and there was an increase in the intimacy, if you like, of the bone contact. And that was compared where they were looking at conventional drilling. So they noticed that there was this improvement. And the only problem is that a lot of these studies tend to be on animals. And so whether it's directly applicable, we can't say. Those of you on my training course in Dubai, the interns there, will know I'm very fond of osteodensification, and we use hand instruments to achieve this. And one of the reasons isn't because I have any great dislike of using conventional drilling. It's just that when you're starting off as a student, you want everything to be as predictable as possible. Now, there's one good surefire way of losing osseo fixation or primary fixation, and that is to over prepare the site. That's guaranteed 100%. And one of the things that novices aren't very good at is perhaps following the drilling sequence or using the drills, going down the right angle each time, and they end up over preparing the site. They end up losing primary fixation, losing bone. It's very destructive. Whereas if they use hand osteodensification instruments, the chances of them over preparing the site and not getting primary fixation are very much reduced. So as a sort of training wheels on your bicycle, then hand osteodensification is a great technique. Also, for osteofixation or primary fixation, you need to have the implant engaged in as much bone as possible. And this very briefly shows a CBCT on the left, and we're placing an immediate implant to replace our lower left premolar here. And what we want to do is we want to make sure that that implant is engaging as much bone as possible. And in this region, of course, we have to be mindful of the mental foramen and the mental nerve, and not to impinge on the integrity of the canal. And we can see on the right-hand slide, we've actually identified in those transverse sections, we've actually identified the exit point for the mental nerve, and we're positioning that implant to move away from that area, to not be close to the foramen because it's higher up. So we're positioning the implant with a slight lingual inclination and a slight distal inclination. And we can see what happens if we position that implant either too buccally, as it can be seen here, and too close to the nerve. We're impinging on that 2 millimeter bone zone, which I often talk about, and the implant's turned red to say we're moving into uncharted and dangerous territories. Here we've segmented the scan. This is a technique that relies on the various densities of the structures in order for us to be able to subtract them. And what we've done is we've removed everything apart from the teeth and the nerves and the tooth that we want to have. The bone has actually been removed. And when I'm planning immediates with students, a good way of showing them this is to sort of say, well, this is the root. And obviously when the tooth comes out, there's going to be no bone in the socket here. So we know that there's going to be bone in this area here. So we want to position our implant so that we have it is as much bone as possible for primary stability. And also we want to have a good clearance from this nerve. We don't want to be, you can imagine if you placed an implant going straight down the root canal, what are you going to hit, where are you going to be. And we want to make sure that the screw goes through the occlusal surface of that thing so we can restore it. And we can see here where our screw access point. So if we angle the implant slightly towards the lingual with a slight mesial tilt, we can still restore it at the end of the day with a screw retained crown, if that is what we want to do. So this is the usefulness of using a CBCT to help plan and guide your cases. And I think it's very useful when you're first starting off. Right? Immediate loading, well, the success rates with immediate loading technique are comparable to the late ones. This is what the paper is showing. But there are guidelines: patient selection, surgical technique, implant design, prosthetic planning. Remember that circle again: host features, implant design features, bone quality quantity, surgical techniques, and restorative protocol. All these take on a much greater significance. And instead of having a great big bridge to walk across, we now have far more risk factors that we have to control and be mindful of if we're going to do these advanced techniques. Now, this is perhaps a nice one to start off with. It's a gentleman with a missing central incisor. We're going to take that out. We can see there's good bone above it. We've extracted it as atraumatically as possible. We're checking the root surface for any bone. And we're going to consider the three-dimensional placement in apical coronal, labial palatal, mesiodistal, and one that's often overlooked when people talk about 3D planning is the angulation. They don't consider that to be a dimension, but I do. They talk about the mesio, the distal, the labial, and of course you can have an angulation mesiodistally, palatolabally. You can have angles, and so you end up with what's called a compound angle, which you have to be aware of when you restore. So we've got an intact labial bone there, very thin. Do you want to remove the periosteum, or do you want to keep the periosteum? What do you think? What do the papers say about that? Do you always need to have an intact labial face, or can you do it when there isn't an intact labial face? What do the papers say about that? This is using hand densification or ossification. Instead, you can use a drilled one. The problem with a drilled one is you're often trying to insert a drill on a sloped surface. The drill's coming in obliquely because of the angle of the socket. So the drill tends to want to slip down the socket and end up in the apex. So using an instrument like this to start your osteotomy site is very good. So remember that on average, when we take out a tooth, you can lose about nearly 2 millimeters of bone in the first 4 to 6 months. And so this will occur if you raise a full flat procedure. So we want to keep the periosteum over that socket. So we don't want to be raising big labial flaps because that's going to increase our bone resorption. So we want to avoid that. And because the other place, 2/3 of the blood supply comes from the periodontal membrane and about 1/3 from the periosteum. So you've removed the periodontal membrane with a tooth, and now you're going to remove the periosteal membrane, and you have very thin bone there, very thin cortical bone there. Obviously, it's going to be prone to resorption. Here we are deciding on our entry point, and we're going to be following this rule. We like to have 3 millimeters of space from the head of the implant to the gingival margin, if you like, to develop our emergence profile for an aesthetic result. This 3 millimeters also works biologically as well. Again, something we can't cover in this presentation, but as a rule of thumb, it's 3 millimeters, 1, 2, 3. Obviously, if you have if you have on the left-hand side, what we have here is from the gingival margin, if you like, to the head of the implant is 3 millimeters. If we have thicker soft tissue, say 2 millimeters, we only have to drop the implant 1 millimeter. Here we have 1 millimeter of soft tissue. We have to drop the implant 2 millimeters into bone. 2 millimeters soft tissue, 1 millimeter into bone, 3 millimeters of soft tissue, you can be flush with the crest. So these are just some apical coronal positioning tips. Here we're using an osseoidentification instrument, and we're preparing that site. We're not using a hand instrument because we want to preserve the bone. We don't want to cut any of the bone away. We take our implant, we insert that implant. The implant is designed for immediate placement in this manner. Not all implants will allow you to do this, especially cylindrical implants. So this is, again, selecting the implant design for the protocol that you're intending to use. Not all of them are appropriate. Now we're placing, and we're going to bury that implant, and you can see here we've got the 3 millimeter rule. We're 3 millimeters below the soft tissue. How do we know this? Well, some systems on the instruments, I don't know if we can show it here, but some of those instruments have marking lines which you can use to eyeball against the soft tissue, and you know you're 3 millimeters in. Depends on your system, of course. And I'm going to jump through this thing here about barrier membranes. Again, we're looking at the healing abutments that we're going to go on top of this. And if you've got healing abutments which have no screw-in or no microgap, that can also help. So we've got a healing abutment here. We're just placing that on top of the implant, and we're left with this situation. Do we want to suture that? Do we want to put graft material in that? Are we concerned about the jumping gap? Are we concerned about A, B, C, or D? Well, again, these are all questions for another day and another course. But this is the situation about 4 weeks later. And we're using a ceramic abutment. This is placed into the case, and this is what it looks like. We've got our implant, a metal abutment interface, no ceramic interface, and then we have our customized abutment made in ceramic there, and our final crown just positioned. And this was the situation, good bone levels at I think 3 years out. And this was the situation when we placed that crown. And that was all done within about 3 to 4 weeks from beginning to end. So it's an example of, I would say, power immediate loading. I don't like, for a number of reasons, which I'll cover in more detail in the master classes that we're going to be running, I try to avoid immediate restorations on the day of surgery unless I'm really pushed into it. And again, I say we'll cover that on the masterclass. So finally, just to finish off with this, we might run 2 or 4 minutes over time. We're going to come to maintenance. And remember at the beginning, I said the host's general health, and I mentioned oral health as well as systemic health, and I included those there. And particularly, we're concerned about peri-implant health going forwards. Peri-implant health to me means the health of the soft tissues and the hard tissues. They're all important in peri-implant health. And we also want to try and maintain the mechanical integrity and functioning of the implants. So when we talk about maintenance in implant dentistry, we have biological maintenance and we have mechanical maintenance. And this is an interesting thing on mechanical complications. And it was a retrospective study looking at immediately loaded complete arch prosthesis, and they're supported on Nobel Pharma implants. They looked at 56 patients. They looked at 72 restored arches, and the follow-up time was 52 to plus or minus 26 months, a little bit low on that. And they said the survival rate was 100%. But they also mentioned in this thing, prosthetic success rate was 38%. So hold on a minute, what do they mean by prosthetic? What's the difference? What is a success rate? What are they talking about here? Right. Abutment loosening was 43%. Chipping or fracture of the veneer material was 25%, and screw loosening again was 21%. So why is there two lots of screw loosening? Well, remember, in a lot of these screw retained prostheses, you have a screw to hold the multi-abutment on, and then you have an occlusal screw to hold the restoration onto the multi-abutment. So you've got two screws. So you've got twice the chance of something coming loose. And this would be where you've torqued them up and all sorts of things. So abutment screw loosening was 43%, 21% chipping of the veneering material. So that's why they had a low prosthetic success rate, because they included these figures, and they included these as failures in the prosthesis. But really, this is standard for a lot of implant dentistry, that there is this mechanical maintenance that's required. And it doesn't really matter what manufacturer of implant you've got. It doesn't really matter who's doing the lab work. These are just to be expected. Expect that you're going to have fractures of frameworks and veneers. Expect you're going to have abutment loosening. So there's a maintenance element to this. Now, certain appliances will have greater maintenance requirements than other appliances. And when you do your consent letter, it's also beholden on you to let your patients know what their maintenance likelihood is going forward. Because if you say to a patient, well, after 5 years, we might need to replace the veneer on your bridge, and it's going to cost you X amount because of wear and tear, they're going to be happy. But if they come back after 5 years with it broken, you've never mentioned it, they're going to expect you to carry out this remedial work, which is expected forever and a day, because you said the implants were going to last a lifetime. They don't differentiate between the bit in bone and the bit that goes on top of the implant. So again, it's very important in your consent letter to make it most clear what it is you mean. So, minor mechanical complications such as screw loosening and chipping or fracture of the veneering material were frequent events, but had no impact on the satisfaction and the quality of life of the patients with immediately loaded complete implant prosthesis. And that is something you do find, is that although there are these mechanical issues, the majority of patients are still very happy with their implants and very happy to perhaps refer new patients to you. They're not so happy, and although it's considered a minor mechanical complication, and it may well be, to the patient's disruption of their life and having to come in and get it sorted out, they don't consider it such a minor thing. So I would say you need to redress this in the consent letter, and you need to do a risk analysis. Finally, we're going to look at the incidence of peri-implantitis, and again, we'll deal with this in programs going forward. So the incidence of peri-implantitis was 28.6% in patients with a history of periodontitis, and only about 6% in those who never had any previous experience of the disease. High and significant risk for both implant loss and bone loss in patients with periodontitis, in those that were periodontally healthy. So if your patient has a history or lost their teeth through periodontal disease, then you can expect they have a higher chance of getting peri-implantitis. And again, when you assess that patient, when you're advising the patient at the start of the treatment, you should also put down a little bit about their periodontal condition, their periodontal history. And we can classify, and when we look at peri-implant disease, I particularly like this. It's very easy. There's more complicated ones. I mean, people love to have these things where they chart out the bone defect and all sorts of things, but I just like this one because it relates to the percentage of bone loss from the implant surface, which is very easy, because if you know the length of the implant and you know the thread pitch of your implant, you can work out the percentage of bone loss very, very accurately, or reasonably accurately, rather than say, you've lost a lot of bone, or you've lost this. You can just work it out as percentage, because obviously, you know, 25% over a 20 millimeter long implant is going to be different in terms of length than 25% over a 10 millimeter implant. And this is why it's nice to look at percentages. So if it's less than or equal to 4 millimeters, you can say it's about 25%. And that would be about 25% of the thing. You could just measure the length, sorry. So if you had a, I don't know, a 16 millimeter long implant and you'd lost 4 millimeters, that would be 25%. If you had a 10 millimeter implant, 25%, if they've lost 2.5 millimeters of bone, then you might say that was very early type. If you had lost 25 to 50% of the bone around your implant in the vertical dimension, then that's moderate. And if you'd lost over 50%, that's advanced. And it's how you manage all these different early, moderate, and advanced types of peri-implant disease that we'll be looking at in our masterclass going forward. Again, when you come to a problem, we have a checklist, and this helps you make your decision-making pathway when you come to treatment planning and what the risks might be involved. So again, this is something we'll be looking at in more detail as we go into our masterclass options. So this is the kind of things that we want to be checking out when we're looking at a checklist for the success of our implant treatment.